Welcome to Fort Worth Innovates, a show about innovation, research, entrepreneurship, and startups in Panther City. My name is Cameron Cushman, and I'm the host of this podcast that brings you the stories of the people that are putting our city on the map as a leader in innovation with the help of the Fort Worth-Tarrant County Innovation Partnership. My guest today is Dr. William Stigall, the Vice President and Chief Research Officer at Cook Children's Hospital in Fort Worth. Dr. Stigall is a pediatric intensivist and bioethicist and serves as an attending physician in the Pediatric Intensive Care Unit. He has led the Research Administration Office at Cook Children since 2022, a large, preeminent, and complex pediatric research program which requires scientific, organizational, and ethical acumen to bring cutting-edge research to children. He's also working with Texas A&M Fort Worth and the Fort Worth-Tarrant County Innovation Partnership to launch a new Biorepository in Fort Worth to spur additional research and collaboration for our tiniest residents. Dr. Stigall, welcome to the Fort Worth Innovates podcast.
Thanks, Cameron. It's good to be here.
Okay, so I just gave a long and very, a lot of words I don't say very often, description of you. But can you tell us what you do at Cook in your own words?
Yeah, so I'm a pediatric cardiac intensivist by training. So a physician taking care of pediatric ICU kids. I'm currently the Chief Research Officer at Cook Children's. So I spend most of my time, virtually all of my time now, standing behind a desk, doing administrative work, helping lead the research program here. But I came to Cook about 8 years ago, working in the pediatric ICU, and then I've had a couple of different administrative roles. And this latest one started 3 years ago as the Chief Research Officer. And Cook's research program is one of the unsung, unknown secrets of Cook, but also of Fort Worth.
I love it. And I wanted to learn more about that. But first, let's zoom out a little bit. Tell us the mission of Cook Children's Hospital. What are some of the current projects that you and your team are working on? Kind of give us a high-level overview of what Cook is trying to accomplish here in Fort Worth.
One of the things I really love about Cook Children's is this, what we call it, it's our promise. So everyone's got a mission statement, everyone's got a vision. Cook has a promise. And our promise is actually pretty jarring. I remember the first time I heard it, I was like, wow, Cook's actually saying that. And now, having been here almost a decade, Cook actually lives this. So our promise is that knowing every child's life is sacred, we promise to improve the well-being of every child in our care and our communities. And that's been shortened now to everything for the child. So the sort of the short version of our promise that uses words like sacred and every child, improve the well-being, is everything for the child. And that is absolutely what I've experienced here at Cook. Clearly, I'm a biased sample. Clearly, I've drunk the Kool-Aid. Clearly, I am, all in. But I am all in, and I've been to multiple other places around the country. And Cook Children's is really a unique place with how mission-driven this place is.
I love it. And I think, any Fort Worthian that's ever been downtown has seen the blue roof and the blue lights at night. But it has a much bigger mission than just Fort Worth and Tarrant County. Can you kind of describe the catchment area for where patients come from that would come to Cook Children's?
So I think what sets Cook really apart, so we're a big hospital, right? So we're one of the biggest hospitals in the country, bed size, volume-wise, that kind of thing. Our ER is incredibly busy, one of the biggest in the country, and there are obviously not that many of these healthcare systems that are as big as us, just on the medical center side. But I think what really separates us is this integrated healthcare system bit. And the integrated healthcare system means that you're not just a hospital. So we are a hospital. Actually, we're a couple of campuses of a hospital. We got this other hospital in Prosper that we're building, that we built up. But we also then have all of these outpatient services. So we've got specialty clinics all over. We've got primary care clinics all over. We've got urgent cares. We've got this giant ER. And so we have this integrated system where if you're taken care of in your kid in our catchment area, your pediatrician is probably working for Cook. Your subspecialist is working for Cook. Where you go to the hospital is at Cook. When you go to the urgent care, you're going to a Cook urgent care. If you need emergency services, you're going to get that at Cook. We've got a transport service that's very big and active. So if you're in the field and you're going to be transported as a pediatric patient, you're going to be transported by Cook. So it's all Cook, and that's an amazing sort of integration that allows both sort of sharing of information, but also honestly like sharing of care. And so not only do we have all this sort of medical integration, then we have all these medical service integrations as well. So Cook it's a health plan. So Cook is the Medicaid provider for thousands and thousands of patients. So those same patients who are on the Medicaid program, they're taken care of by the same system that's providing their insurance. They're the ones providing their medical care. Cook also then has a physician network. So all the physicians, the vast majority of the physicians that work for Cook Medical Center work at the same network. So on the sort of medical admin side, we're all on the same team. And then we have a DME, a medical device and medical equipment company. And so when you have a kid who's been in the NICU for several months and they need to go home on a ventilator, we've got a rehab program that teaches the parents how to do these things. We send them home, and we have a ventilator program that supplies them with a ventilator. They come back to an outpatient pulmonology clinic where it's all the same doctors and all the same network taking care of them. And it's hard to tell people outside the medical system how important that is. There's so much data loss and information loss and how to navigate all these streams when it's all under the blue peak. It's so much better, not just administratively, it's better care.
That makes sense. Under the blue peak, I like that. And I think most people in Fort Worth and Tarrant County understand that Cook treats kids, right? Treats pediatric patients. They help their families. You just hit on a bunch of other things that I didn't know about, that's for sure. But I think most people would also be surprised to learn about the amount of research being conducted at Cook, and this is your world. This is what you're in charge of. So can you tell us a little bit about how research works at Cook and what that would look like? Educate us a little bit.
So this everything for the child, and again, I know it may sound a bit like an infomercial, but I'm a believer in this, and it's a really interesting place that it really is everything for the child. And so everything for the child, when you're this big, includes research. So, the most obvious example of this is in a very real difference in the pediatric world versus the adult world, like in cancer. So in the adult world, less than 5% of patients with cancer are on a trial for their cancer, even though there's hundreds of trials, right? The adult world is just much more fragmented, and it's not near as collaborative as the pediatric world. So peds in general is more collaborative than the adult world. We're also a lot smaller, right? And so in the pediatric world, we very quickly recognize that to get anything done in pediatric cancer, you need to be on trial. There's just not enough pediatric cancer to really figure out what's going on at any one place, to set up their own shop and do their own thing. So in the pediatric world, in general, if there's a trial open, you will be taken care of at a place that does pediatric cancer research. And the proof is in the pudding for that. This is one of my favorite statistics to give, is in 1950s, when pediatric cancer starts to become researchable, the mortality for the most common form of cancer was greater than 90% in 3 years. So you're a 7-year-old diagnosed with lymphoblastic leukemia, which is the most common form of pediatric cancer. You're diagnosed with that in 1955, and they tell you that your odds of surviving are less than 5% over the next 2 years, right? Now, fast forward, if you come into Cook today and you get this awful diagnosis as a parent that your child has cancer, and it's this lymphoblastic leukemia, you can say now, for standard risk for the normal kind of pediatric cancer, your odds of survival for the next 5 years are 95%. And that's
Wow.
amazing, right? And that's happened because we do research in pediatrics, especially in oncology, in this iterative fashion where every kid who gets diagnosed with leukemia ought to be on trial because it's going to get the latest and greatest, best innovation. And then we pool all that. So So you're now Cook Children's, you're the pediatric provider for our catchment area, and you're going to be hit with kids coming in who have cancer. And so everything for the child then means, okay, we're going to treat them, and the best way to treat cancer is by putting them on trial, and so we're going to be a part of that trial. So in the United States, there's two major players in these collaborative groups for children's oncology. One is COG, the Children's Oncology Group. This is the bigger one. It's dozens of pediatric health systems are part of the COG group, and they collaborate all together and have the latest and greatest in pediatric care. The other system is the St. Jude's network. So St. Jude's Research Hospital in Tennessee, most places are members of one or the other. Cook is members of both. So we actually were the first pediatric hospital outside of St. Jude to run St. Jude's trials. This was about 20 years ago. And so since then, Cook is now a member of both these kinds of consortiums. So all of a sudden, you've got Cook Children's Hospital taking care of patients. And if we're going to take care of kids with cancer, which we take care of the whole catchment area, we got to take care of kids with cancer, and we want to do everything for the child. Now we have to do research. So the difference between Cook and a lot of places, though, is that we're not part of an academic medical center. We don't have a giant academic partner that has a logo on our building, right? And so then how do you take care of pediatric cancer when the vast majority of places that are doing this kind of thing are parts of academic medical centers where you've got a research infrastructure that's sort of built in the water? So that's why Cook then created the research administration organization about 20 years ago to basically decentralize and administer all this sort of research. So it starts with oncology because you can't do pediatric care without doing pediatric oncology. You can't do pediatric oncology without doing pediatric oncology research. And that's where it starts. But now it's grown to actually where we do more research outside of oncology than we do inside oncology. But it's all that same metaphor that when you're this big and you're taking care of this many patients, seeing this kind of patients who are this sick in neurology and endocrinology, in hematology. Well, if you want to do everything for the child and you're seeing all these patients and you can do all this stuff, then you ought to be giving them research opportunities as well. And so that's where our office helps with all of that.
Love it. That's fascinating. So tell me how you and Cook initially got involved with Texas A&M Fort Worth and the Fort Worth and Tarrant County Innovation Partnership. How did that process start?
Well, so I came on this job about 3 years ago, and previously to this, I'd worked on the IRB, the Institutional Review Board, the Human Research Protection Program. So the Research Administration Office is the administrator and organizer of all the research we're doing at Cook, and then the IRB, the Human Research Protection Program, judges those output of here's what we want to do these proposals, and they say, okay, that's safe, that's ethical. So I'd seen a bunch of stuff coming out of REO from that side of things, but when I came over here on the operations side, I went and started looking for what all are we doing, what are we doing well? What can we do better? That kind of thing. So I kind of did an all-campus tour of what's going on, and part of that tour then was, okay, who are stakeholders outside of campus? So we started, kind of poking around, and then I heard that A&M Fort Worth was coming to town. I was like, what do you talk A&M Fort Worth? What is that? So as soon as I sort of heard this, I was like, whoa, that's I'm a sailor, and I said, that's a battleship that rolled into town. And friend or foe, when a battleship comes to port, like the waves start moving. The world is not the same before and after A&M moves to Fort Worth. So I kind of poked on that. I'm like, what are you guys up to? What are you doing? And it was one of these onions that I kept peeling back. It's like, wow, that sounds like a really, really interesting idea you're up to with, I'm sure you've had podcasts on this of how innovative the approach is for A&M Fort Worth. So because they're creating something here that's different than almost any other place that I've known, because Cook Research is also a bit of a unicorn. Then I started poking on A&M to say, okay, can I hear more about what y'all are up to? And it's just one of these things. Again, the time and place that we're in North Texas, the time and place we're in at Cook, where we're in the world, is a really special set of coincidences. And there was just immediate resonance with what A&M was doing and what Cook is already doing. And then it's obvious to me about where this thing heads, is that, we have real needs to get the word out and to have partners of scale and scope that A&M can do. And then A&M for sure can use what we're doing here to their benefit as well.
Very cool. Yeah, and it is interesting seeing all these big institutions right here in Fort Worth that don't necessarily have the notoriety that they deserve, but they're doing really incredible work and people just don't know it. So we
Yeah.
mentioned in the intro this notion of working together with A&M on a biorepository. That's a fancy word. Tell us what a biorepository is and why is that important for Cook, Texas A&M Fort Worth, and for just the city of Fort Worth?
Yeah, the story of the biorepository actually is kind of telling on a lot of these points. So in my internal tour, I'm poking around, asking people what they need. What do we do well? What do we not do well? What do you want us to do better? And this idea of a biorepository kept coming up. So I had at least 3 or 4 different investigators on campus telling me that for the next stage of what we need here is I need to be able to collect our tissue and save it and then study it later, right? You kind of hear this a couple of times. I start poking around on this, and it turns out we do a lot of taking out of tissue, right? So anytime you do a surgery, anytime you're doing a procedure, there's all this sort of tissue that you're dealing with, and then we actually send away a lot of tissue. That these cancer trials, for example, we are sending away tissue for research on the kind of cancer the kid has, on future drug development, that kind of thing. So you start hearing this a couple of places, and like, oh, that's an interesting problem, and then you sort of thinking about like, how much tissue are we throwing away? And you start doing some of that math. You're like, oh my gosh, there's a world of data that we're not actually using. So we, with my sons, we biobanked their umbilical cord stem cells, right? And the idea is you've got stem cells. You're never going to have those umbilical cord stem cells again. But what if your kid gets cancer when he's 7? What if he gets cancer when he's 20? Wouldn't it be great to have your own stem cells back there, right? So we're banking those things personally. So just multiply that out, right? So you can imagine if we had some general program where we're collecting tissue for people, and then we can use that tissue for them later. Wouldn't that be interesting, right? So then A&M calls a summit of the local constituents, right? So we're there on the hospital side, the healthcare system side. A&M's also got interest in the aeronautics side and the workforce development side, all those things. So it's this big room, and they got us all together, and it really was like ideate. Like, what do you guys need? And I thought this was an incredible position for A&M to take, is like, okay, the battleship rolled to town. We're rolling to town, but we're actually friendly, and we want to know what is it that having an institution that's one of the world's biggest, what could it do for you, right? And so the healthcare group got around, and we were ideating. So yeah, we need more people. We need less burnout. We need more training. We need more equipment, and this is where then I started talking about, well, one of the things we're looking at doing is biorepository. And so in the Cook way, we're everything for the child, and we do a lot of investment, honestly, in research for the clinical care of these kids, right? And so I've got parallel streams going right now, currently, on how to build a biorepository out, because I've got clinicians who say they need a biorepository to take better care of the kids. And so we start talking about this in our healthcare group, and other hospital systems are also like, well, that's a good idea. We have that same exact problem, right? That we don't have this research program, we don't have a biorepository, but for sure we've got this thing. And then A&M has a similar problem set where they got this giant research infrastructure, but having real tissue to point that research infrastructure towards. Oh my gosh, what could you do with that, right? I just got back from the World Medical Innovation Forum, which is one of the great conferences on innovation up in Boston, and the CMO of Merck was there, and he was asked, what's your special sauce? Why do you think Merck is so successful? And literally the first or second thing he said is, well, we think our biorepository is one of the reasons why Merck is so successful. And so it's just the idea of, like, if you've got access to this tissue, there's so much power that gives you clinically to go and give yourself your own stem cells, but also to understand what's actually going on. So now you have cancer, and if we had your stem cells or tissue from you from 7 years ago, what predisposition did you have, if any? And then therapeutically, if we have tissue, then can we design something for you? Knowing something about you, can we give you a better drug? Can we design a drug for you? All that stuff is in the offing now, but you need the tissue, right? And you need the data around that.
Love it. So where are you in the process? Is this up and running? Do you have space identified? When do you think it'll open? When will you start taking samples?
Yeah, so this is still largely in the ideating phase at this point. But that said, it's not. That doesn't mean it's not real. So just for example, so we have a biorepository, but what that means is I got a couple of shelves in a refrigerator and I'm tracking it, right? And so. I mean that's effectively all you need at the micro scale is okay. We got the tissue, we're preserving it, we know whose it is and where it came from and why we're preserving it, and we've got a purpose for that, right? But what we're ideating on is scale. So I don't know if you remember in COVID, where were you looking in COVID for what's going on? And I was looking at two places. I was looking at the UK Biobank. So the United Kingdom had the best data on what is COVID, what happens with COVID. And the reason why they had that was because they have the National Health Service in the UK, and they have a biobank that connects all of the National Health Service. So the UK Biobank is just one of the world's best. And so when COVID came, more quickly than anybody else in the world, what happens to people with COVID? This kind of person does this kind of person does that. So I started tuning my ear to what happens with COVID to the UK very early. And the second place I turned was then Israel. So once we started getting therapies for COVID, Israel became the place to look at, and because they have a similar sort of integrated system, they're able to track everything, and they were the first in the world to tell us that we needed here's what vaccines do. They are the first in the world to tell us that we needed boosters, right? So if you take the UK Biobank and you look at that kind of model and you put it in North Texas, one, we could be bigger, like just because we're big, right? Two, the big difference between the UK Biobank and what we could do here in North Texas is UK Biobank looks like a bunch of Brits, right? The North Texas Biobank, if you did this right and you got partners and from the pediatric side and the adult side, we look like America. Um, that would be incredible if we had that kind of rich data set, rich tissue set for drug development, for therapeutics, for monitoring of things, for both your clinical care for the person, but also the public health, community health perspective. So what you would need then is you need clinical partners that were big. Well, see previous comments about us being one of the biggest integrated pediatric healthcare systems in the country. We're big, but we are in the shadow of two giant adult healthcare systems, right? So THR and Baylor are giant integrated healthcare systems, and then JPS is our safety network. But between the three of those, they care for all of the millions of people in Tarrant County in our catchment area, and then we're the pediatric provider. So that's a pretty unique situation. Like, doesn't even exist east in the Metroplex, right? The Dallas market is completely fragmented compared to the West Metroplex. So between these three giant adult facilities, this one pediatric facility, you now have all of these people taken care of by just a handful of healthcare systems, and we're all in the same electronic medical record. So now you have this ability to have all this data and people swimming in the same space. So then you would need some giant partner to help you with that, right? To help organize all those things. And then this battleship rolled into town.
Sounds more like a mercy ship than a battleship, but
It
not.
is. That's probably a better approach to it. It's a large vessel.
Yeah, well, and I think your point about the diversity of the Metroplex is so true. If you're Hispanic, if you're Black, if you're of Asian origin, diseases affect you differently, and we don't understand that. Especially in like some neurodegenerative things, we just don't even know what that looks like in people. And so, to be able to tap into that diversity is I think a huge strength of the region that we typically forget about.
Just to feed off that point around diversity and the importance of diversity, not just because you want drugs that were developed for people that look like us, but now with AI, right? You need a model that looks like the population. And so if you're modeling your population on the United Kingdom, that is not an appropriate model to look at the American population on. Or if you're modeling your population on what looks like the East Coast or the West Coast, the East Coast and West Coast also do not look like America, right? So those are, the East Coast is depopulating. The pediatric population is going down. It's got a very different racial makeup and ethnic makeup than we do. We are a booming population that is ethnically and racially diverse. Those are better models to build your AI systems on.
Hadn't thought about that, but that makes a ton of sense. I love it. So let's go back to the research for a second. Can you tell us about some of the most promising research being conducted at Cook right now?
So our largest area of research that we do is oncology research, but we do more research outside of oncology than we do oncology research now. And so at any given time, last year we had about 500 studies that were open. We about two-thirds of those, about half of those actually are about our clinical trials. So at any one time, there's about 200 something clinical trials going on at Cook Children's. The rest of those then are database studies, registries, that kind of thing. The deepest area of research that we're doing, so oncology is probably our widest. The deepest area of research right now is in neurology. So we're actually really, really deep in the neurosciences. We're probably the best or one of the best in the country at neuroimaging for certain kinds of epilepsy. And so this is our deepest well right now is in the neurosciences and multimodal neuroimaging for drug-resistant epilepsy. So that's a bunch of words, but what it gets at is you got kids got really hard to treat epilepsy. And so drug-resistant epilepsy is kids who have genetic dispositions for epilepsy, or they've had injuries that give them drug-resistant epilepsy. And so the path for drug-resistant epilepsy means that you're on multiple drugs, you've got lots of seizures all the time. And one of the endpoints of that then is, well, okay, surgery. So you either take out the part of the brain that's got the seizure focus, or you laser it or ablate it in some way. And so then if you're at that stage, right, you would like to take out as little brain as possible. You want to surgically cure this thing in the most precise way. And so then you need imaging to figure out, okay, where exactly is this thing coming from? And so right now we have one of the best programs in the country at localizing where seizures come from. And we do that through a bunch of different ways through multimodal. So MRI, high density EEG, transcranial magnetic stimulation, and functional testing. And so we're able to sort of figure out where this thing is better than almost anybody. That's in this, this world of drug-resistant epilepsy. It's not a very big world, but it's got adjacent to that is epilepsy, right? And adjacent to that is movement disorders, and adjacent to that is anything wrong with the brain. And so our neurosciences are our deepest area of research currently, but it's all clinically focused, right? So we're not interested in doing research for research's sake. We're doing research so that we can best treat these kids who've got these very difficult to treat diseases. Endocrinology generally is our next sort of biggest one. We've got a couple of niche areas in endocrinology, like there's one called congenital hyperinsulinism. And congenital hyperinsulinism is this really terrible disease where your pancreas produces too much insulin. And so these kids come out and they have really low sugars when they're first born. This can cause brain injury, cause seizures, and we have a program. We're one of two centers of excellence for CHI in the country. So if your kid has hyperinsulinism, it's not a very common disease, but if he has it, he should be treated by us or by CHOP and Children's Hospital of Philadelphia. And that's amazing to know that we've got one of the largest programs in the world in this. We also have other areas in the endocrinology space that are also pretty well developed. We are growing out more and more research in precision medicine. We've got some interesting things going on in gastroenterology, pulmonology, orthopedics. So we've got these pockets of really deep research. And then one of the things that we're doing, and one of the reasons I'm interested with A&M is strategically focusing these things, of sort of building these things out, and let's get a real plan of what's next in neurology, what's next in oncology, what's next in endocrinology. And so that's the phase we're in right now in research.
Wow, I had no idea. Thanks for educating us. That's really fascinating stuff, and I love hearing that Fort Worth is the one of the top in the country for some of these kind of things. That's really reassuring to hear and wonderful. But does that research ever lead to startup companies or spin out technologies? Do you ever license your technologies or your research to other companies, either startup companies or big companies?
Yeah, this is something I'm interested in. So, the innovation space is not that's not my lane per se. So my lane is the research administration at Cook Children's. And so what I would like to tell people is, like, I'm also not the medical education guy. So I'm not the med ed guy, but research lives next to med ed. In the same way, research lives next to innovation. So, for example, we have scientists who are working on projects that we're funding because we think they're going to advance clinical care, but they're spilling out intellectual property, right? Like they're coming up with new ideas. Um, we're so focused on the clinical side of things, though, that we're not actually all that advanced in the spin out phase of things. And so, it's a bit like the tissue. I think that we give away a lot of tissue to collaborators, around the country because it's the right thing to do. It's the right thing to share our data. It's the right thing to share our tissue. And this is all done under protocols, and we've got consent and all that, right? But I'm sending a lot of data away, and I'm not abstracting all that same data here and putting it to our purposes yet, right? Because we're focused on what does this clinician need, what does that clinician need, and we're just now sort of like raising our horizons. So the short answer is that we haven't done a lot of spin outs, but I think we're totally ripe for that kind of thing. And I think that's actually what's going on in the world today politically, with the disturbances going on at the federal level around research. I think what that's showing is like, okay, the system has gotten a little creaky. And we need a way of speeding this thing up. We have incentivized people to do things that are not just for the clinical care of patients. And so if you're incentivized to publish papers, that's a different incentive structure than I'm incentivized to cure cancer. I'm incentivized to make this person walk, right? You can publishing paper. We like publishing papers. I think publishing papers is a very good thing, but our primary focus is on the clinical side of things. If you go to the clinical side of things, then, and you do the research infrastructure like we're building out, you're going to start hitting into innovation, that there's not going to be a protocol that allows you to solve this problem. You need to actually go just solve the problem yourself. So we're getting into earlier and earlier phases of clinical trials. We're doing some first-in-human trials in our neurospace. We've got a gene therapy for an epilepsy where we're one of the first 2 sites in the world to do. So we're getting this really, really deep expertise, and innovation, I think, it's this next horizon that's coming on.
Very cool. Yeah, I love hearing that. And yeah, startups, spin outs are really, really hard, and there are very few institutions that do it very well. But you also have to have the basics of the research to make that happen and enable that. So I want to shift now to something that we talked about previously. I know you're a big fan of teaching your team how to think like an innovator or like an entrepreneur. Can you tell us a little bit about some of the work that you've been doing to kind of bring that innovation, that entrepreneurship mindset to the folks that you work closely with at Cook?
Yeah, one of the places that I first met you actually was at an innovation conference, and you introduced me to this concept of sort of the entrepreneurial mindset, and that was something I've been noodling on and hadn't quite realized that that's where I was heading. So the entrepreneurial mindset is this idea that I think is a couple of things, but one, the first most important thing is, okay, what problem are you trying to solve for that stakeholder, right? So it's not just interesting to you. Your interesting idea only has real interest if it's actually solving somebody else's problem, right? And in the poetic version of that, that's empathy. You actually have to care about somebody else and what are their needs and how are you going to solve their problems, right? So I think it's one side of things. The other side of the entrepreneurial mindset is constantly improving, constantly looking for a better way, constantly looking for an efficiency, constantly being critical of your processes. So what we've done tangibly over here is one, actually we just had graduation a couple of days ago, where we put all of our uh, research administration office employees through a white belt program for Lean Six Sigma. So we've got a really great process improvement program here at Cook. They offer belts, the white belt, the green belt, the yellow belt, that kind of thing, the black belt, and Lean Six Sigma. And we worked with them to offer a white belt, which is sort of the lowest of these process improvement things, right? It tells you how to process map. It tells you what process improvement is. It kind of gives you this taste of this mindset. But now we put everyone through it. And that's the kind of commitment that we have to, okay, all of these protocols, I mean, they come out and it's a 400-page protocol of here's how you're going to do this study. There are 1,000 ways of doing that thing, and there are going to be more or less efficient ways of doing it. There's going to be better ways of doing that, worse ways of doing that. So what I'm trying to give our people just on the administrative side is like, okay, there's got to be a better way at this, right? But then in the higher level, the sort of the more meta level, is putting yourself in the frame of the patient you're taking care of the clinician you're trying to serve. How can we solve their problems, right? Now spin all that up. If there are techniques to this kind of thing. If you could bring that kind of mindset to this organization, very quickly you're going to have emergent ideas. Things are going to get better. We're going to come up with new techniques. We're going to come up with innovations, and then we need to cycle all those things back. That's what I'm super excited about here at Cook, is that we've got all these pieces that if you've built the system, we've got all of the patients who are coming to us with all their problems. Because we're so big, because we have such deep expertise across all these specialties, we see rare disease all the time. So we've got these clinicians who are master clinicians. They can see all of it in ways that most clinicians in the country don't have. Then we've got this research infrastructure that we can do almost any trial. Based on what we know how to do and all the rules and the regs and making sure it operates smoothly. Then, if we can have some people bubbling up our own ideas, now you've got this entire research ecosystem that just needs to start to spin, and all for the good of the child, right? Um, this is one of the reasons why I'm interested in the A&M side of things, around the innovation side of things, is we can be so focused on what our problem sets are. Now, if you bump up against somebody who says, well, you're testing out things that are known and what's the best way to do that, A or B. I'm telling you there's a C out here, and I can give you a new thing, a new device, a new drug. Or you got a problem set that's got a kid with a disease that doesn't have a drug. Well, tell me what that is. Give me some tissue, give me some data, and I'm gonna go and invent a drug for you, right? So I think that's what I'm super excited about. But it all requires having sort of an eye to, let's do the best possible work right now with what we have, and then looking outside of that. Hey, is this frame completely fixed, or is there another way at this? And I think, Cook's got that history. Fort Worth's got that history. That's kind of in our DNA.
Okay, so Dr. Stigall, tell us where you think the Cook Research Program is going to be in the next 5 to 10 years. Look into the future for us and tell us where you're going to be in the next decade.
Wow. I A decade is way too far.
Okay.
What was 2015 like? And in 2015, go predict 2025, right? So this is actually, I'm a planner, and I would love to have planned that out, but I've been taught by life that what I'm looking at is like 3 years, 4 years, right? And that's a much more reasonable place to go. Bigger, better, faster, stronger. I think we're in a really, really interesting space right now. In all of the dimensions, I think Cook is in a really, really unique position in the world, honestly, for what we're doing, what we can do. But that's just one small piece of Fort Worth's in this really interesting place. Medicine is a really interesting place. The country's in a very interesting place. So the short version is, we do more of everything. We do deeper of everything. We get better at everything, and Cook is committed to that. That because we're a boom town, we're going to see more of everything. Our patient population is going to demand more of us, right? That's just a quantity problem. But the other part of this really interesting space here is where we are in technology, where we are in the translational research, where we are in the use of artificial intelligence. We really are in a phase shift for what we can know. And Cook is in a really, really interesting place for that. So the COVID example, I think, is a great story for this. That mRNA vaccines. So whatever you want to think about mRNA vaccines, they did not come in overnight, right? I mean, this is 20, 30 years in the making. And what happened with COVID was the ability to scale these interesting research ideas going on at small scale. And then all of a sudden you had this giant problem, and you're able to look at that problem, right? So that's what's going on in a boom town like Fort Worth. So there's very few boom towns that start with 1 million people, right? It's this kind of really interesting scenario where, like, we're growing, but we're already big. So now we've got scale everywhere. What scale everywhere means then is that all these problems to solve are going to become bigger problems, right? That these one-off little things that if you were smaller, you'd only see once every couple of months or years. Now we're going to see those things, every week, right? So the combination then of the scale problem or the scale opportunity that we have, plus all of this translational research that's kind of been cooking for the last 20 years, now it's ready to be applied clinically. And so for the first time ever, we can design drugs for people, right? For the first time ever, we now have the computing power, the scientific understanding, the biomanufacturing capabilities of like, you've got a disease, okay, and it's got this genetic defect. Okay, well, we can just go create a molecule to fix that defect. I mean, that's amazing. And so, I think platform is one of the words I use quite a bit. That just for an example, designing designer drugs for individual patients. So we can do that for almost anything, right? I mean, it's just a matter of time and money and people and process and all that sort of thing, right? So it's not efficient and there's not enough resources to do it for all the things. But if you can find a platform solution, and so there are several kinds of diseases that are amenable to this. And so then all you then need to apply is the platform. And so I think that's the area we're in of, what all can we use monoclonal antibodies for? So COVID showed us that we could use monoclonal antibodies. We can scale those things up and fight a virus with it, right? What else can we use monoclonal antibodies for? We now know so much more about the immune system post-COVID than we did pre-COVID. And so now it's just application. And so then Cook's position there is, well, we got a bunch of kids who have a bunch of immune problems. And so we've got the ability to do these trials. We've got kids who have rare diseases, but now we are so big that we have an aggregate of rare diseases. And so let's just start applying the platform to solve these problems. That scales all the way up. That we're like that on neuro, we're like that on endo, we're like that on immunology, we're like that on oncology. And I think it's a really, really special place that Cook is in. And then AI. Right. I mean, so one of the reasons why we have all of this ability now is that we've got computational power we just did not have 10 years ago. That what would take years, months, millions of dollars, right? Now we've got all of this horsepower, and there's horsepower coming to town that knows how to really do this. And not just talking about generative AI that you can, your chat GPT kind of things, but real deep AI that you can apply some serious computational power to that we just never had before, and like modeling out how we design a molecule for this. It's a really, really interesting place.
Well, in innovation speak, you're talking about convergence and convergence exponentials, these ideas that all this stuff is now existed, it's all come really far. It just takes someone to kind of put it together in a new and different way. And you're absolutely talking about so many examples where that could apply, and hadn't really thought about it. But we did actually learn a lot out of COVID, as terrible as it was on so many different things. Man, that advanced science in a huge way, in a really fast way that no one would have wanted. We wouldn't have predicted that, but we did learn a lot as a community because of that.
Absolutely. Absolutely.
So the last question we always ask on this show, Dr. Stigall, I want to know, what is your favorite innovation in Fort Worth right now?
This. So I'm super interested in Fort Worth continuing to be Fort Worth. And what I mean by that is that, so I'm not from here. I grew up in Houston and Austin growing up. I married a girl from Fort Worth, and I didn't know this Dallas-Fort Worth thing when I was in Houston and Austin. I didn't know it was DFW. And so I didn't know this kind of complementary, antagonistic relationship that Fort Worth and Dallas have, right? So I get up here and I go to medical school in Dallas, and I meet my wife, and she's from Fort Worth. And so that was kind of my first education about what Fort Worth really was. And I'm a bit of a nerd, and so I kind of dove into Fort Worth history when I moved over here. And Fort Worth's a really, really interesting place, right? There's so much cool about Fort Worth, the history of Fort Worth. 100 miles west of here has something like a foot less rain than 100 miles east of here. Like we're on the 98th parallel is a thing you can see from space. So then this sort of westward look we have creates a very different kind of culture than literally just 100 miles east of us, right? So if you then sort of take that and then you look at the history of Fort Worth, we're just one boom town after another, right? It's these crazy people who come out here and they go find cattle, and there's just cattle running everywhere, and they create the cattle industry, right? And then we do crazy things like drive it 1,000 miles north to put it on trains. Um, then similar things happen with oil. It's these wildcatters who come out and they just take risks, and there's natural resources abounding, more than you know what to do with. But you have to have people who are like, I can go do that, and I'm gonna do that, and I'm just gonna make it up as I go because there's no technology that tells me how to do it, right? Um, A&M coming to town and doing this thing, this giant academic system that then plops down an institute that's sort of shared by the entire system. That's a crazy idea. Like that's a really, really cool idea. So then the public-private partnership thing, the idea that you're going to have these aeronautic industry leaders on one floor and have, grad students and undergrads taking engineering classes on another floor, that's a really, really cool idea. The idea then that they come to town and they ask the people of the town, like, what do you want? What do you need? I think that's a really, really cool idea, right? So I think all that's innovative. And you've got this situation now where we've got all this natural resource. We've got all these people, we've got all this technology, we've got all this sort of know-how and grit and determination. And it's this like place that cares about each other, right? So it's not just raw capitalism. It's this sort of community that's got this long history of doing it our way for everyone's benefit. And I think we're just now in that next phase. Like it's like I said, I'm a bit of a history nerd, and the metaphor of the Fort Worth boomtown, the Fort Worth Innovation Complex, like we've been doing this for like 150 years, and we're just now in this next phase of it. So my short answer is, what's my favorite innovation right now? I think it's Fort Worth. Fort Worth is just this innovation thing, and I love all the things we're doing.
Well, it really is where the West begins, right? That I think that's a very much a truism in a lot of ways, and I hope we end up in the spot where it's where the future begins. Dr. Stigall, thank you so much for joining me today on Fort Worth Innovates. If you like hearing stories about innovation, research, entrepreneurship, and startups in our city, please subscribe to this podcast, share it, and be sure to tell a friend. The more you engage, the more episodes we get to bring you. Fort Worth Innovates is produced by Kendall Rogers. We'd like to thank our sponsor for this podcast, the Fort Worth-Tarrant County Innovation Partnership, who are building an innovation district where technology and research combine to build the future right here, right now.